Good morning to batch 22. I am Dr. Jitendra, Assistant Professor from Neurosurgery. So, कितने लोगों को पता था कि आज ये वाला टॉपिक है? कितने लोगों ने देखा था अपना रोस्टर? तो पढ़ा है? चलो 8:05 तक वेट करते हैं, जितने लोग आ जाएंगे फिर शुरू करते हैं. To start with, can anyone volunteer what is difference or similarities between definition of head injury or traumatic brain injury? Or both are same or different? Anyone? What is traumatic brain injury and what is head injury? What is considered? For latecomers, who can volunteer for the question? What is difference between traumatic brain injury or head injury? No one want? Yes, please. Injury to the good, very good answer. So in recent we now using more refined term, that is traumatic brain injury, but head injury is an umbrella term which includes all the injury of the head, scalp, soft tissues, muscles, face also. So but from the old days it is using, so now also people are using the term head injury, but in literature most of the people changes to the traumatic brain injury. Traumatic brain injury is specific to the brain. Thank you. Sit. So what is the concept? Why head injury is, why someone is head injury, why it is so? Because brain is preserved in a compact chamber. So whenever there is an injury to that skull, that force will transmit it to one side and to all over other sides, the coup and counter coup. So this is the logic behind the head injury. So, and in head or the cranium also there are various compartments that are present in the cranial cavity but are separated from each other. That is, anterior cranial fossa is separated from middle cranial fossa, is separated from posterior cranial fossa. All are lying in the cranial cavity, but due to membrane inside them, that is the tectorial membrane or the sagittal sinus, they all behave like a separate compartment. So trauma to the one compartment will behave like other type of trauma to the other compartment, same trauma. So, what are the mechanisms? So, mechanisms can be static or dynamic. On the basis of the duration, it is divided. If duration is more than 200 milliseconds, it is called as static injury, or if it is less than 50 milliseconds, it will be termed as dynamic. So, static injuries may cause skull fractures, or the dynamic can be of two types: impact loading or impulsive loading. In impact loading, it is due to the combination of the contact and the inertial forces. In the impulsive loading, there is only inertial forces. So, contact forces, what are they? They can be local, which can cause fractures to the vault or the skull base, which can lead to hematomas, epidural, subdural, or the remote injuries, while the inertial forces cause diffuse axonal injury, diffuse injury to the brain. So, how we can classify the injuries? We can classify into trauma, which can lead to skull fractures, focal brain injuries, or the diffuse injuries. Fracture can be to the vault or to the skull base. This we think consider as a vault, and this is the skull base. So, fracture can be linear or the depressed. Focal brain injuries can be direct contusion, which can be coup or the counter coup, or hemorrhagic, can be classified under extradural, subdural, or intracerebral, or the diffuse brain injuries. That is the most grievous injury can be diffuse axonal, and most light injury is concussion. Both are type of the diffuse brain injuries. In other classification, this classification is older one, when literature or academics are present only in the military. So, at that time they have divided into missile injuries and non-missile injuries. Missile injuries are usually gunshot injuries that are penetrating inside. So, missile injuries with entering to the brain, that is a bullet injury. The primary injury is caused by the bullet, but there are other changes due to the heat, mechanical forces, other changes also. So, this is the older one classification. When academics happens and only military, then they divided into missile and non-missile categories to the head injuries. So, what is the impact? How the force transmitted to the cranium or the body? So, it can be direct impact to the assault or the accidental fall, or indirect. Indirect, what it means? In reference to RTA, when a vehicle collides to a body, there is transmission of the force, usually below the hip to the legs. That is the primary impact, and then the object collide with secondary to the car, and after that is called secondary, and after that he fall away from the car to the road, that called tertiary impact. So, in reference to the RTA, we can divide impact in primary, secondary, and tertiary. And how we can explain coup and counter coup? Coup is the point where direct force transmission has happened, but since there is direct transfer of the forces to the cranium, but since brain is a enclosed in a closed chamber, so for every action there is equal and opposite reaction. So brain floats again back to the force impact side, and there is injury to the contralateral side, which is called as counter coup injuries. This mostly happen in secondary impact. What we get information from this primary impact, when there is transfer of the force to the body, at that time there is primary impact. At this time the patient is having primary impact to the body, and at the same time the force will transmit to the other side and will lead to counter coup injury. So these are the various modulating fracture that affects the brain injuries. So what is the mode of transmission of force? That is the extent and size. What are the modes? On the basis of modes can be road traffic accident, missiles, fall or assault, or the blunt trauma to the head, or pre-existing conditions also. Easy over any medication, anticoagulants or diuretics, nutrition status of the patient, or the under influence of any psychotic drugs or alcohol. Causes of the brain damage, that can be focal lesion. Then on the site of the impact there can be a fracture beneath the scalp laceration, and intracranial hemorrhages, that could be epidural hematoma or subdural or interparenchymal hemorrhages. There could be injuries to the vessel inside the brain, and diffuse lesion can happen, which can be diffuse axonal injury, diffuse brain injury, that can lead to raised ICP. So these are the secondary finding due to trauma to the brain, which can lead to diffuse brain edema, or it could be axonal injury, which can lead to raised intracranial pressure. How intracranial pressure raised? What is Monro-Kaling hypothesis? Do everyone read? Anyone? What does it say? Same thing, the brain is present inside a closed compartment. So inside that cranial wall, only three things can stay. One is brain, other is CSF, third is blood. If any of the three things increases, other two have to decrease. So in chance of trauma to the brain, there will be inflammation and edema that can lead to decrease in blood flow to the brain, that can cause secondary injury to the brain. What is the normal intracranial pressure? Can anyone volunteer? Normal intracranial pressure values. It depends on the position of the body. In standing, it could be -5 centimeter of water, and in supine position it can be 0 to 2. And what we consider raised ICP? Raised ICP is considered when there is a 22 centimeter of water column. Then we consider as raised ICP. And the sequel of head injury, what we discussed, raised ICP will further lead to brain hypoxia by decreasing blood flow to the brain. Many hypotheses were given, but most accepted and old one theory is this: the trauma will lead to early deterioration that can cause the deterioration of the mechanoporation within minutes to hours, that lead to the transient separation of the cell membrane. Receptor and channel proteins got disrupted, which lead to influx of the potassium inside the cell and influx of sodium, calcium chloride outside. And then there is a closure of the defect by calcium activated channel, but then it can be mild head injury or severe injury. In case of mild injury, this process will return by closing of the calcium channel, and in case of the severe injury, there were no closure or defect, and further loss of the calcium will lead to toxicity. How we can explain and microscopic features: focal damage to the parenchyma, minor contusions, that are the hemorrhages that can lead to deposition of the blood, which can disintegrate into the hemosiderin and will further lead to gliosis. And other thing we can describe in diffuse axonal injury, there is the shearing due to the acceleration and deceleration. There is shearing. This is a neuron, and due to the trauma there is stretching, which called shearing of the neurons. And in this is the representation of a neuron of diffuse axonal injury, which we term as a axonal retraction or axon balls. This neuron, when it got tear, will bulge at the site and form axonal retraction or axonal balls. This is a normal anatomical description of a neuron, cell body, axons and the button. So first thing, can anyone give a volunteer definition of concussion? What is a concussion? Injury to the brain. Yes, please speak up. Functional loss. Clinically we sit please. Clinically we classify head injury in concussion, minor, moderate, severe. In concussion, for evaluation of head injury, we took three major histories. Is there any history of LOC, loss of consciousness, which can be retrograde or anterograde, or examine patient on the basis of Glasgow Coma scale. So when Glasgow Coma, what is the full score of Glasgow Coma? 15 by 15. And what is the least score? 3 by 15. Good. So when GCS is 15 by 15 and patient don't have history of LOC, so we will consider it as no head injury. But 15 by 15 with a loss of history of 10 minutes, we will consider him under concussion with normal CT finding. So normal CT finding can happen in two people, perfectly normal or concussion. Concussion patient will have a history of loss of consciousness, but normal patient won't have history of loss of consciousness. And after that, on the basis of GCS, we divide them into mild, moderate and severe. So this is a picture showing brain edema. This is a cadaveric sample of brain to emphasize you to see what are gyri and sulci. In CT scan, there were no differentiation between any sulcus and gyri. There is a diffuse edema. No. Compare this picture with first one. The sulcus and gyri is visible in this picture, but there was no differentiation between gyri and sulci. Diffuse brain edema. And this is a pictographic. This is a post-mortem finding of a patient. showing diffuse brain edema. The sulci are all gone, only gyria is visible. Now we will consider each injuries with pictographic and CT findings. So this is a postmortem specimen of a patient showing contusion over the right frontal lobe. So these both are from the different patients, different subjects. So in CT it will appear like this. These hyperdensities are blood. How we can differentiate this hyperdensity of bone or blood on the basis of which units? Hounsfield units. To eyes, both things we are seeing as white. And on the basis of Hounsfield unit, we can identify what is bone, what is blood, what is CSF, what is grey matter, what is white matter, what is normal calcification. So on the basis of Hounsfield unit, we can categorize. Usually the Hounsfield unit for blood is 60 to 70 HU. For bone it is 1000. For air it is minus 1000. For CSF it is 0 to 5. For grey matter it is about 50. For white matter it is 40. To remember easily. So this is the postmortem specimen, and this is the CT findings for separate patient, but to compare. And this is a cartoon representation of other hemorrhages. Left side is representing epidural hematoma and right side is depicting about the subdural hemorrhage. Epidural hematoma usually associated with fracture of bone. It can be bony or vascular. Usually, mostly it is associated with skull fracture, with seepage of the blood from the marrow above the dura, which can lead to formation of a epidural hematoma. Sometimes underlying vessel, vein or artery get also ruptured, that can lead to EDH. Then we call this as a arterial or the venous EDH. Bony EDH will have good prognosis because these bleeding stop itself, but vascular hematoma will grow. In neurosurgery, only the EDH is having good prognosis. So we don't leave EDH at any time. What you people should know, usually associated with fracture, can be present with rupture of vein or artery, that meningeal artery, which lead to the accumulation of blood between the bone and the dura. Usually it is fusiform, and we will discuss separately for the SDH, but on this representation, when blood accumulate within dura above arachnoid or pia, then it is called subdural hematoma. Basis of pathology is the bridging vein between the brain and cranium got torn, and there is a leak of blood beneath the dura, which lead to a sickle type bleeding pattern. It's called known as subdural. How we identify? We identify with, if blood is inside sulci, then we will consider it as a subdural. If there is no blood inside the sulci, then we will consider it as a EDH. So this is a postmortem specimen of a subject having left parietal. This is the dura, this is the brain we expose. So this blood is lying above the dura. This is dura mater. This is the covering of brain. What are the three coverings of the brain? What are these? Pia mater, arachnoid mater and dura mater. So this is the dura, the brain is exposed. So blood is present outside the dura, then it is called extradural or epidural. How it appears, both are from the different subjects. So, it is a fusiform shaped, usually do not crosses sutures, because at sutures dura is toughly adhere. So, usually they do not crosses sutures, but SDS crosses. This hyperdense is the blood on basis of HU. This is the same representation. What we have explained, that there is toning of the bridging veins that can lead to the accumulation of blood beneath the dura above the brain. This is the coronal section. If you want to imagine, this is the cut section represented here. So, blood accumulated beneath the dura. This is also postmortem specimen, and this is representation from the different subject, showing two different stages of subdural hematoma. The dura is separated from the brain, and this is clot, and beneath that clot is the brain. So, there is bilateral SDH. It is in the chronic form, it is not in the acute form. So, which can have poor prognosis, EDH or SDH? If two patients came to you, one is having EDH and another one is having SDH in the same compartment of equal volume, who will have poor clinical examination and poor prognosis? SDH will have. EDH patient will present with lucid intervals. They will give the history of I have a history of LOC, but now I am perfect. There is nothing to do. Can I go to home? You can ask such things. There are intervals, lucid intervals. Then patient suddenly fall and become comatose. Such type of history present in EDH, but they are having good prognosis because brain matter is not facing the blood that cause irritation. Blood is outside the dura, so there is no irritation to the brain, only mass effect. So, once we remove the mass effect, patient will be perfectly alright. But in case of SDH, there is rupture of inside vessel that can lead to further deterioration. Venous return hamper, brain edema increases, ICP increases more often, and will have poor prognosis. And then we can have interparenchymal bleed inside the brain. It is less. Usually it is present at tiny contusions, but hematoma is rare. When we call it hematoma, when 70% of the region is compromised, accumulated by blood only, then we call it as a hematoma. Otherwise we call it hemorrhages, tiny hemorrhages, when there is punctate hemorrhage all over the body. This is also a postmortem specimen showing blood inside a cavity. Representation from different subject as a patient. The the blood is lying inside the parenchyma. And what is most dangerous sequel of the head injury is diffuse axonal injury. The CT appears as normal, usually with diffuse edema. The sulci gyri are lost in this patient. This type of feature we can get on postmortem. Petechial bleeds, with usually bleed around the corpus callosum, and this is the MRI representation, T2 section with hypointensities in favor of bleeds. So, diffuse axonal is a clinical diagnosis when there is a disproportionate GCS fall in reference to CT scan. We can identify it only in either in the postmortem or in MRI. So patient with normal appears to be normal CT brain can be of three type: normal, no LOC, concussion with LOC, or with disproportionate decrease in GCS. I let it consider it could be 4 by 15, 6 by 15. The disproportionate CTs appears normal, but GCS is 3, 4, 5. So then we consider diagnosis of diffuse axonal injury. It is the most severe form of the injury where the total brain got tiny contusions, which can only be identified on the MRI sections. So over to you. Any questions? Anything? For head injury, another lecture will happen with for the clinical examination by other faculty in successive sessions. We can have any interaction? Yes. Most common morbidity causes now is RTA or the assault, usually associated with head injury. So in any setting you will get trauma more and head injury with head injury. You can have many questions to ask. The pathophysiology and anything you want to ask. अब ये बताओ कितने लोग हेलमेट लगाते हैं, बाइक पहनते हैं, बाइक चलाते हैं? तो हाथ उठा के बताओ। 2 ही लोग, बाकी सब प्लेन से आते हैं। वैसे प्लेन भी सेफ नहीं है। कितने लोग लगाते हैं हेलमेट? सबको लगाना है, डिस्टेंस चाहे जितना भी कम हो। ओपीडी में इमरजेंसी डिपार्टमेंट में लेस देन 1% पेशेंट आते हैं जो हिस्ट्री देते हैं कि हमने हेलमेट लगाया था और अस्पताल आए हैं। जो हेलमेट लगाता है वो घर ही पहुंचता है, अस्पताल कभी नहीं आता। ठीक है, तो आज के लेक्चर का ये इम्पोर्टेंट है, कम से कम तुम लोग हेलमेट लगाओ, 4 आदमी को और बताओ। डिस्टेंस चाहे जो भी हो, एक्सीडेंट कैन हैपन एनीथिंग। आप 100 मीटर सोचो, उसमें भी एक्सीडेंट हो सकता है। यू कैन ओनली प्रिवेंट। एक बार हेड इंजरी हो गया तो देन तो फिर ट्रीटमेंट ही करना है, सीवियर हो गया तो और ही खत्म। सो अगेन, एनी क्वेश्चंस? एनी अदर इलस्ट्रेशन समवन वांट्स? No questions? Yes? Okay. Attendance shall be started.